Welcome to the Doctor Podcast Cykiert File Show, where we dive into groundbreaking medical advancements with leading experts. This is episode number 123, and I'm your host, Dr. Robert Cykiert. Today, we're honored to speak with Dr. Edward Holland, an internationally renowned ophthalmologist and director of cornea services at the Cincinnati Eye Institute, as well as professor of ophthalmology at the University of Cincinnati. Dr. Holland is a pioneer in treating severe ocular surface disease, which we'll talk about in detail. It's a condition that's causing corneal blindness that affects tens of thousands of people annually due to birth defects, chemical burns, or autoimmune diseases of the eye. Through the Holland Foundation for Sight Restoration, which he started, the only organization of its kind, by the way, Dr. Holland is transforming lives by advancing ocular surface stem cell transplantation and establishing centers of excellence across the USA and globally. His innovative Cincinnati protocol, which he developed, combines advanced surgical techniques with systemic immunosuppression, offering hope to patients with limited treatment options. Join us as we explore how Dr. Holland and his foundation are breaking barriers to restore vision and improve quality of life for those with severe visual impairment. So thanks very much, Dr. Holland, Ed, for taking time from your busy day to join us today on the Doctor Podcast program. We appreciate it.
Well, thanks for having me. It's a very, very important group of patients. I think one of the biggest unmet need, certainly in cornea, but in all of ophthalmology. And I
Right.
appreciate your interest in allowing us to kind of tell the story.
Right. So I'm a cornea specialist as well, and I've had patients with this condition, and it's extremely difficult to treat and very frustrating. So I'm glad you're doing something about it that will be very helpful for tens of thousands of patients. So to start, tell us what severe ocular surface disease is, what causes it, and what symptoms patients have, what problems patients have, and how it's extremely difficult to treat it.
So if we talk about severe ocular surface disease, we're really talking about the conjunctival and cornea epithelium. And really wasn't well understood until around 1990 when the understanding of where the regeneration of the epithelial layer came from for the cornea. And so if you look back at a lot of corneal transplant studies, they would look at success rates and they'd see that for keratoconus or corneal scarring, our success rate was very, very good. And standard penetrating keratoplastic success rate in Stevens-Johnson syndrome, chemical injuries, thermal injuries was terrible.
Right.
And when I first started doing transplants, in the mid 1980s, we kind of treated everybody the same. Everybody got a penetrating keratoplasty for corneal disease, but there's a group of patients that did poorly. It was really the understanding of this anatomy, and several of very good basic scientists and translational researchers made us understand that, first of all, there are stem cells for the cornea that are at the juncture between the conjunctiva and cornea, called the limbus. And the basal layer of the limbus gives rise to daughter cells which repopulate the ocular surface and give us that clear, transparent, healthy epithelium that allows our patients to see. If we have a injury or a medical condition that affects those stem cells, then we don't have a source of that skin layer, and scar tissue or the tissue around the white part of the eye, the conjunctiva, invade. And this tissue is thick and has blood vessels and is opaque, and of course the patients don't see. And the second part of the story is we, for several decades, concentrated on the limbal stem cells, but we also have to understand there are conjunctival stem cell areas in the fornices and throughout the ocular surface that give rise to the special epithelial layer of the ocular surface around the white part of the eye, the sclera. And so, we talk about limbal deficiency, but really it's conjunctival and limbal deficiency that give us this group of patients with severe ocular surface disease. In fact, it's the patients that lose the conjunctiva and they'll go on to lose the limbus and their corneal clarity. those are the most difficult patients we have to manage, the conjunctival plus limbal deficiency. And there's categories of conjunctival disease and categories of pure limbal disease.
Right. And so these patients, basically, the cornea normally is crystal clear, transparent, like a clear window pane. When they have this severe ocular surface disease, the cornea turns hazy and cloudy. It's almost like looking through a frosted glass window instead of a clear window pane.
Yeah, so two things happen. We can talk about the common diagnoses. Chemical injuries, thermal injuries are kind of at the top of the list. Inherited disorders, and there's a condition called aniridia, in which it's a dominantly inherited condition in which children are born with either partially or no iris, and hence the term aniridia was applied to these group of patients many decades ago. But they also have other things wrong with their eye. They have problems with cataract, glaucoma, and retina development. But unfortunately, what really causes them to lose the majority of their vision is their stem cells drop out in the second or third decade, and their cornea becomes opacified. So we have chemical injuries, thermal injuries, inherited disorders. Then we have a lot of dermatologic conditions that cause scarring of the skin that lead to the same stem cell dropout that we see with aniridia. And these category of patients are called ectodermal dysplasia, was one big category of patients. And then some of the what we call autoimmune disease, so reactions in the body that can cause scarring of your joints or scarring of your muscles or skin, can cause the same problem. And one of the real common ones is Stevens-Johnson syndrome, which is kind of a typically allergic reaction that leads to a chronic inflammatory systemic condition. And these patients often are quite ill acutely. And the worst patients are actually, because they slough their skin, are managed in a burn unit,
Right.
but they often recover and become healthy again. But the long-term sequelae is inflammation and scarring of the conjunctiva and the limbal stem cells. So when you lose your stem cells, you have no skin on the cornea, and without skin on the cornea, we see scarring and thinning. Kind of a reaction the eye has to save itself is to grow scar tissue into the cornea to try to prevent thinning and perforation. And that scar tissue, while prevents perforation of the cornea, leads to more opacification and blindness. So ultimately, these corneas have dense scarring. They kind of turn white. And in the past, clinicians would think, well, I've got this scarred cornea. The acute episode's over. Why don't we just do a transplant?
Right.
But when you do a corneal transplant, the full thickness corneal transplant comes from the eye bank, and there could be some donor tissue, a skin on that donor cornea, but that ultimately sloughs in weeks to months, and the patient has to grow back their own skin layer. And that's where a stem cell deficiency patient cannot do that. And the success rate, if you do a full thickness or a partial thickness corneal transplant in total limbal deficiency, the success rate is zero.
Right. Yeah, I remember doing transplants in patients who had Stevens-Johnson and other conditions, and they always failed. And initially, we didn't understand why. Now we know why. And fortunately, thanks to you, we now have a new excellent way to treat it. So now the Holland Foundation for Sight Restoration, which you started, is the only organization dedicated to addressing unmet need of corneal transplantation for severe ocular surface disease. Can you share what inspired you to establish this foundation and how its mission to create centers of excellence aims to change the landscape of care for these patients?
Yeah, and to be honest, I don't get credit, Robert. It really goes to a gentleman called Robert Dempsey. Robert Dempsey has been in industry and ophthalmology for many, many decades. He's been with the big ophthalmic companies. He's been with startup companies, and he's a friend to a lot of ophthalmologists. And he was actually visiting in Cincinnati and came over for dinner. And we were just talking at the end of the evening, and he picked up my cornea textbook. and kind of randomly opened to the chapter of ocular surface stem cell transplantation. This is kind of a crazy story.
Right.
And he said, I didn't even, tell me about this. You've written this chapter, and there's a picture of a severe chemical injury, and then he flips the page, and then there's this beautiful clear cornea. And he said, how does one go from that diseased eye to that clear cornea with good vision? So I kind of told him the story that we were talking about, and I said that we have to find stem cells from either a deceased donor or a living relative and place them on the eye, rehabilitate the ocular surface, then we can form transplants. And he was kind of saying, he's known me for many, many years, but didn't really know that that was a big part of what I was doing because he knew me as kind of a consultant for his pharma companies he worked with. So he said, I'm so moved about what you do. I want to donate to your foundation. And
Wow.
I said, Bob, I don't have a foundation. And then he said, shame on you. You should have a foundation because
Right.
how many of these patients are being treated? And I said, not even 1% of these patients being treated. So Bob Dempsey that evening decided on his own, and he dragged me with him to start the Holland Foundation for Sight Restoration. So I
Wow.
give Bob credit.
That's a great story. I happen to know Bob Dempsey well
Yeah,
because
yeah,
when Xiidra first came out, which is a treatment for dry eye disease, I worked with him and used to give talks about Xiidra
yeah,
to
yeah.
other ophthalmologists. So
Bob
yeah,
gets
he's an
credit for bringing,
incredibly
yeah, yeah.
smart, nice guy, very innovative, and he's been a great addition to ophthalmology. The Cincinnati Protocol, which you created, is described as a management concept that integrates systemic immunosuppression, collaboration with kidney specialists known as nephrologists, and a dedicated transplant coordinator. Can you take us through the key components of the Cincinnati Protocol and how it draws from kidney transplantation principles to improve outcomes for severe ocular surface disease?
Yeah, Robert, I'd like to kind of talk about how we got there. So if we
Yeah,
think back about, the late 80s, we were doing full thickness transplants for these patients that were all failing. And then the
right,
discovery of the anatomy of the ocular surface and the location of the stem cells. And then several investigators, and I didn't come up with the original procedures, but had these ideas and the original procedure was actually for unilateral disease, taking stem cells or tissue off the good eye and treating the bad eye. And actually, Barricare in the mid 60s at the very first World Cornea Congress. Now he didn't know where stem cells were located, but
right,
he had the idea to do an autograft or cells from the good eye to the bad eye. And so that actually was the very first ocular surface transplantation. But then the understanding of the anatomy and the evolution of different techniques, and so really it's kind of come down to two basic techniques. Well, I say three basic techniques. The patients with unilateral disease, and they have a very good chance of rehabilitation because we can take cells off the fellow eye and transplant them to the diseased eye. So we call that a conjunctival limbal autograft. And why does it work so well? Well, obviously the patient can't reject their own tissue.
right,
And if the eye is managed properly preoperatively and the inflammation is managed and the eye is quiet, the success rate is outstanding. The question we always get is, what's the risk to the donor eye?
right.
And we along with others have kind of modified the conjunctival limbal autograft to take about 40% of the limbal stem cells off the donor eye and transplant those cells. And we've never had a patient lose vision from that surgical procedure. So it's a safe procedure. Now, if the fellow eye had any history of partial trauma, multiple surgeries, long-term glaucoma drops, contact lens wear can actually stress stem cells. So we
Yeah,
eliminate any long-term contact lens wear. So conjunctival limbal autograft is the first one, but really the majority of patients we take care of have bilateral disease. And even if the fellow eye has moderate disease versus severe disease, we never touch the better eye. It's not worth the risk of making that eye worse. So we basically have two ideas. We can take, and the original idea was actually using a living relative and taking the conjunctiva and limbus off, one eye of the relative to the disease eye. And when that was proposed kind of in the early 90s, I think a lot of surgeons were reluctant to operate on a healthy eye. And so
Right.
the next operation came from using a deceased donor. So we can take a donor globe. We really can't get conjunctiva, but we can get plenty of limbal stem cells off the periphery of that donor cornea. And so actually in the early 90s, that kind of was tried by many, many surgeons. But here's where the real failure occurred, and it took us many years to figure it out. As ophthalmologists, as cornea specialists, we really don't understand the art of systemic immunosuppression, right?
Right.
No kidney surgeon would think about doing a kidney transplant and not using oral anti-rejection medications. They wouldn't think of it. So in ophthalmology, a lot of surgeons tried these procedures in the early 90s, and they used a little bit of prednisone, a common rapid anti-inflammatory, and then maybe a short course of, at that time, the leading systemic anti-rejection drug, cyclosporin. But really, for 3 months was kind of the average. And all the procedures failed. So there was this period between 1990 and about 1995 where I remember starting to do these procedures using a low dose protocol like that. And I will tell you, Robert, kind of every corneal surgeon gave up. They just said the technique's flawed. It doesn't work. We're not going to do it. I happened to be at the time at the University of Minnesota, and I got to know the head of kidney transplantation, the head of general surgery,
Mm.
one of the leading kidney transplant surgeons in the world. And he was talking about my research, and he was saying to me, why are you using such a short course and low dose? I mean, that he said to me, is the tissue vascularized? I said, yeah, unfortunately it is. He said, there is no way that you could ever get that tissue to work and prevent rejection. So it was kind of in the mid 90s. And I think one of my major contributions to the field is at that point, even though, I didn't have the in-depth training of a lot of transplant surgeons with immunosuppression. I had done another fellowship after my cornea fellowship in ocular immunology at the National Institutes of Health, and did have experience with using a lot of these medications. So I just decided at that time, I'm going to adopt what the kidney transplant surgeons are doing. I'm going to go all in and treat these patients 100% like
Wow.
kidney transplant patients. And it was interesting. We were doing it at Minnesota, but I couldn't get as much collaboration. I couldn't get their team to kind of take over my team, and we had some success. But it was really when I moved to the University of Cincinnati and the Cincinnati Eye Institute, and I reached out to the head of renal at the University of Cincinnati, and I said, I need help, and if you will help me manage my patients, I think we can really change the lives of a lot of people. And it was really the year 2000 I moved here, and it was the commitment of the University of Cincinnati nephrology department. And in fact, they at the beginning they managed my patients, and we'll talk about the importance of a transplant coordinator, the nurse who oversees all the care, the medications, the tracking of the labs, the side effects of the medications. So we were basically rolled into the renal program at the University of Cincinnati, and that's when our success rate totally took a different trajectory. And
Wow.
that's what differentiated our program from the rest of the world is we were all in. And that is one of the main obstacles I think other corneal folks don't have. So Robert, what happened after about 3 years, and I would meet with the renal team and we'd if they would change their protocol, we'd adapt and change ours. But he called me into his office. He said, listen, you're doing more ocular surface transplants than we're doing kidney transplants. So you need to build your own team. So go out there and find money and hire a transplant coordinator. And so we
Wow.
slowly rolled and built our own team. We've had a lot of good collaboration. We have a wonderful partner in St. Elizabeth Hospital here in Northern Kentucky that helps us with our transplant coordinator. We still have tremendous collaboration with the renal department at UC, and we were allowed to build something special. So the Cincinnati protocol is basically uh, taking what a renal or a liver or a heart transplantation, what they would experience, and modeling our patient's experience with that. So it starts with the transplant coordinator, right? So when you go, if you need a renal transplant, you're going to meet with the surgeon, you're going to meet with the nephrologist, but you spend a majority of your time with the transplant coordinator nurse who is kind of overseeing all your care. And that's what we have on our team. And whereas in organ transplantation, there are codes that Medicare, you can charge Medicare or commercial providers that will pay for a transplant coordinator. Unfortunately, in ophthalmology, we don't have that.
Right.
We don't have enough numbers to try to get that. So the transplant coordinator the source of his or her salary has to come from another source. It can't be the hours they work, and they can't bill for their time. So that's a workaround that we've really had to deal with when we talk about starting centers outside Cincinnati.
Wow. When I first heard about your foundation, I said, wow, that's incredible. He did that over a year and everything's running smooth. The story's fascinating because it took you many years, couple of decades to get this all done.
It really did. It really
So
did.
an overnight success that took 20 years in the making. So why are corneal specialists around the country kind of resistant or hesitant to do this? You mentioned now we get a feeling for this. Is it possible to replicate the Cincinnati protocol, which took you many years to get going at your center, and get other people around the country and around the world to do the same thing?
So it's interesting, Robert, when we first started publishing our better results, and with living related matched tissue, our success rate could be, depending on the diagnosis, because some diagnoses have a better, but somewhere between 50% for the worst diagnosis up to 85% for the
Wow.
best. And with deceased donor tissue, a little less, maybe about 60, 75%, because rejection is higher in a deceased donor than as a living donor. So we always, our first go-to, if we can, is to find a relative and get some tissue matching. But I think when we started publishing better results, there were a lot of skepticism, like we don't know what he's doing, but I'm not sure his results are real because nobody else has results like him.
Right.
And there was a lot of, it was for the early years, people didn't believe me, to be honest with you. But I've trained enough fellows and enough people have been here to see my post-op patients that are 6 months out, 2 years out, 10 years out, 15 years out, 20 years out to see that we have the success I'm talking about. So I think the barrier is number one. I think a corneal surgeon just doesn't have the training to be comfortable using full immunosuppression.
Right.
And those who even tried to do it didn't do it the right way. They, back in the 90s when they were having failure and rejection, they may have had a friend in rheumatology or a friend in oncology. Right. But systemic immunosuppression for transplantation is very, very different from medications used in oncology and rheumatology. And really, we've changed our protocol multiple times based on what University of Cincinnati renal team does in terms of the testing we do preoperatively, which really, the workup we do preoperatively, we do tests that nobody in ophthalmology uses,
Right.
like a panel reactive antibody test to determine what risk the patient has about receiving a transplanted tissue. It's routine in renal, never done in cornea. We do it routinely in all our patients, but we learned that from renal. So one is they don't have that partnership with nephrology, and sometimes it's hard to make. Number two, there is this responsibility. If you're the treating surgeon, you're ultimately responsible for the patients taking these medications. And I think a lot of corneal surgeons remember systemic immunosuppression from their medical school days when they saw maybe sick oncology patients or very sick diabetics who were getting renal transplants and how sick they were. But
Right.
you have to understand the majority of our patients are young and healthy, and the complications from these medications on a 25-year-old with a chemical injury versus a 60-year-old diabetic who has high blood pressure, high cholesterol, obesity, cardiac disease are very, very different. But
Right.
it's hard to convince a cornea person, And then the third big obstacle is really understanding the role of the transplant coordinator. We don't have somebody in the clinic we could just pull into that. We have, as you know, we don't even have nurses anymore. We have technicians.
Right.
And we need somebody with a nursing background, and it really takes an outside funding source to pay for his salary. So with those obstacles, I thought we could publish our results and convince people to go ahead and try this. And really, in discussions with Bob Dempsey and Dick Lindstrom and Steve Lane and members of our board of directors, we really realized that we need to create a different way to reach corneal surgeons. So instead of, we've published textbooks on techniques and management, and everything we do is in the literature. It's in the peer-reviewed literature. But we've decided the other pathway is really, we need a passionate quarterback of the team.
Right.
And that quarterback actually has to be a corneal surgeon, right? So we need a corneal surgeon that'll say, all right, I'm all in. I believe what you do. I'm going to adopt the Cincinnati protocol. I'm going to find funding for a transplant coordinator, and we're going to start this process. And so it would be hard to convince a lot of senior cornea people to do it. They're kind of stuck in their ways. So what we've done is look for these younger corneal surgeons who are brilliant and they're motivated. And we've gone, kind of region by region in this country and found those who are interested. And that's how we're going to build our Center of Excellence around a passionate, dedicated, motivated quarterback, corneal surgeon.
So these are people who finished their fellowships like 3, 4, 5 years ago and are very busy, but
Yes.
want to take on this challenge.
Yeah, and a lot of them are at academic centers, so it really helps to have a passionate chairperson who
Right.
believes too, because and I'll say the first center we built, Cincinnati was, in terms of centers of excellence, we're the first one. It was University of California, Irvine, and the reason why was, my old friend Roger Steinert, who was chair, and unfortunately he passed a few years ago.
Right.
But he saw me at a meeting and he had recently read one of our papers and he's like, I practice in the Cincinnati metro area, but actually my office and my surgical center is in Kentucky. People don't realize about a third of Cincinnatians live over the river. And I'm
Wow.
here, the airport's very close to where my office is. So Roger would say to me, how can you do this in Kentucky and we can't do it at University of California, Irvine, and I said, Roger, shame on you. And so
Right.
it was Roger's willpower that really started to build that program. And, the
Wow.
young surgeon that we built it around, Dr. Marjan Farid, she's brilliant, she's dedicated, she's a great surgeon. And she was, really loyal to Roger, and Roger was her great mentor. And she said, I am going to do this because I want to do it, but especially because Roger wants to do it. So they had a center, and we reached out with her and found somebody in nephrology that would be on her team. We then raised money through our foundation to hire her first transplant coordinator, which we've done, and she has built that team. Now, other parts of the team are important in ophthalmology. Half the patients have lid disease. If you have a chemical injury, you get a burn of the eyelids, or if you have Stevens-Johnson syndrome, you scar your eyelids. So you need an oculoplastic surgeon. More than half the patients have glaucoma, so you need a dedicated glaucoma surgeon. And I will tell you, these patients are probably the glaucoma surgeon's kind of worst nightmare. They're very challenging because their
Right.
tissue is not normal. And then, of course, you need a good retina specialist because of all the retina issues. So we have this ophthalmic team headed up by the cornea specialist. We have this collaboration with renal, and then we have the transplant coordinator, and that's tying into to form what we call the Cincinnati protocol.
Right.
And after that success, the next place we went to was the Massachusetts Eye and Ear Infirmary. Uh, Dr. Thomas Dolman and Dr. Jia Yin had talked with me after one of my lectures, and we had, I went to visit them, and we had talked about, how can we help set up that program there. And interesting enough, Dr. Thomas Dollmann's grandfather, the famous Klaus Dollmann, invented the Boston keratoprosthesis, the artificial cornea that has been used for these patients, and I do think it has a role, but they have a lot of complications if you have severe ocular surface disease. So
Right.
I give Dr. Thomas Dollmann credit to want to expand the way he approaches these patients. And so our third center was open at Harvard, and they're up and running and doing patients and doing a fantastic job.
Yeah. Now, I think you're opening centers in Tel Aviv and Israel also, and in Toronto,
So
Canada. Is that right?
we one of my former fellows, Claire Chan, is at the University of Toronto, and she was doing kind of things on her own, and we kind of put her into our protocol, and she's kind of part of our educational group now, and so Toronto is certainly online, and she's a very busy ocular surface transplant surgeon. There's a very good group of surgeons in Tel Aviv. Unfortunately, the war has kind of slowed that progress down, but we'll definitely make that happen. We're working with surgeons in Tuscany, in a big eye clinic in Grosseto, Italy, and they're going to be part of our group. In the last year, we've now have a collaborative effort going on at the Wilmer Eye Institute at Johns Hopkins, and then most recently had conversations with Wills Eye Hospital in Philadelphia. The next center probably to really come online is going to be the University of Illinois Chicago with Dr. Ali Jalilian, another one, a former resident of mine who's worked with me, and we're getting them up and running, and then University of Michigan.
Wow, that's awesome. What about Bascom Palmer? They should get that too, no?
Yeah, so far they haven't reached out. So they do a lot of ocular surface work down there, and of course an incredible ophthalmology department, and certainly would be happy to collaborate with anybody who wants to collaborate. So we think we have kind of figured out, at least for now, the best approach for these patients. We figure out what doesn't work. We figure out what's worked. We understand the importance of using the latest anti-rejection protocols that were really, and why renal? Well, renal was the first, right? Renal, the first successful really kidney transplant program was kidney, and they are kind of the leaders for everyone, and we kind of follow their lead. And we now categorize patients. You think about a patient who had probably the fourth leading cause of why we have limbal stem cell failure is contact lens wear. Now there's tens of millions of contact lens wearers, and 99.9% of them do well, but a small percent end up getting limbal stem cell failure, believe it or not, and
Yeah.
it's kind of a silent disease because while they're wearing their lenses, unless they have kind of annual checkups and their ophthalmologist or optometrist kind of looks at their limbus, they'll miss it because their eyes really don't hurt until the loss of stem cells bring that bad skin layer toward the center of the cornea. But the rest of their eye is normal, so they actually have the highest prognosis because we're dealing with just a single kind of threat to the eye. So let's say we take a patient like that with that diagnosis who has a relative that's a excellent match. I mean, that would be the lowest risk patient we'd have. And then let's go on the other side of it. We have a patient with either severe Stevens-Johnson syndrome and chronically inflamed eye with eyelid scarring and glaucoma, and they don't have a living relative. We have to use deceased donor. They're at the highest risk. So we don't treat those patients all the same, right? We can use less anti-rejection medication for shorter duration on the low risk patient, and we are going to use, not only the maximum immunosuppression, but we're also going to do some treatment protocols for high risk patients using renal, giving monoclonal antibodies pre-op and post-op. And again, these are things we all learned, but we kind of look at high risk, medium risk, and low risk to kind of categorize our patients to how we're going to manage them post-operatively.
Right. The interesting you mentioned about contact lenses. I've had about 3 or 4 patients who developed stem cell damage from contact lenses. Fortunately, I caught them pretty early, stopped the lenses, but it can take them a year, 2, 3 years
Yes.
for the
Yeah.
epithelium to
It's
recover.
interesting because all these patients can be caught on time if someone would just look at their superior limbs. That's where they fail first. But many of the patients, they can order their contacts online. They don't go in for annual
Right,
exams anymore. And the reason why we're seeing it is because they're wearing these lenses for years. Their eyes don't really hurt. And by the time we get them, they have, 360 degrees limbal failure and they're in trouble. And it's always bilateral. Now, it may be a bit asymmetric, but most of the
right.
patients have bilateral visual loss.
Right. And they get frustrated because they always want to start wearing their lenses once they're
Yes,
feeling a little bit better. But I tell them you can't do that. So that's a problem.
yes.
Now, what's your foundation's website? I'm going to post it with this video interview so that people can access it.
Our website is Holland Foundation for sight.org.
Okay.
One word, yes.
Okay. I'll make sure I include that. Now, you have some interesting and inspiring patient stories like that of Kirk Kozak, whose vision was transformed through ocular surface stem cell transplantation. Can you share some other memorable patient stories that illustrate the life-changing impact of your work and the Cincinnati protocol?
Yeah, a couple of patients really stand out. One is was a uh, a gentleman that was in the Middle East wars. He was serving in Afghanistan, and there was an explosion,
Mm.
and he got a chemical thermal burn to both eyes, and actually several of his platoon died in that accident. And he was air back to Germany. He got acute management, which was very good, but then sent to one of the military hospitals with totally opaque corneas and really can only see light and dark and very, very frustrated, as you can imagine. Um, and received the Purple Heart for his work, his duty to this country. So unfortunately, the military hospital looked at the cornea and did a corneal transplant, a
Right.
regular corneal transplant, which failed. He then was discharged out of the army and went back home to southern Georgia, where he has 8 children, 8 kids.
Wow. Eight.
And he went to a very famous university in that area, southeast United States, and they did a corneal transplant in his other eye, which of course failed. And he went back home, and you can understand his frustration. Now he's had 2 transplants, and both institutions are told him there's nothing to do. You just have to live with blindness. So he went to another university where they told him he could have this artificial cornea. And again, artificial corneas, especially the Boston keratoprosthesis, is a wonderful device. But patients with severe ocular surface disease have a severe dry eye and abnormal skin, and they need to maintain that skin layer right against the plastic optic of this artificial
Right.
cornea. He melted it and ended up getting infected and actually lost the eye to an infection inside the eye.
Yeah.
So now he goes back home. He has one eye, 8 kids, and is sitting there and is angry at the world, which I don't blame him. And so his wife wouldn't give up. His wife said, "This is, I can't believe we can't offer my husband more than this." And
Right.
she went back to one of the universities she went to, and she said, "You've got to tell me where to go. I don't believe that there's nothing to do." And the doctor there said, "Well, there's this one guy in Cincinnati that might be able to help you." So he came in, and I'll tell you, I walked in the room, and he was such an angry man, and he wouldn't let me examine him. He was swearing at me like it's a waste of his time.
Wow.
His wife was crying, and his 8 kids, they were breaking my equipment in the exam room. They were all over. It was like a nightmare. So I called his wife out into the hallway. I said, "Listen, I understand your husband's anger, frustration. I don't blame him.
Right.
But I also have an idea based on his medical records. I think we have a very good chance of getting his vision back. But I need you to go in and change his attitude because I need him to be on board. He can't think he's going to fail."
Right.
So she went back in the room, and 2 hours later, she called me back into the room.
Two
And
hours.
2 hours, and I walked in, and he was He was, yes, yes, doctor, no, doctor, whatever you say, doctor, I'll do whatever need. He totally had an attitude adjustment. Long story short, he got his vision back. He's got 20/30 vision. He drives his car.
Wow.
He has two children that are competing for the U.S. Olympic wrestling team.
Wow.
They're in that youth league. They're outstanding athletes as he was, and it's just a great story because it
It's
was
incredible.
his wife that wouldn't give up. She said, "I don't believe there's nothing left for my husband."
Wow. She's a tough wife. I would have loved to be a
Yeah,
fly on the
yeah,
wall during those 2 hours.
yeah, yeah.
That's a fantastic story.
We had another young man from Kansas, and believe it or not, he was a winemaker. Now, people wonder why you're making wine in Kansas. But prior to Prohibition, Kansas was a leading wine producing state in the U.S.
Really?
Obviously, yeah,
Wow.
obviously California, Washington, Oregon's kind of surpassed him, but they still make decent wine. And he was he was doing a demonstration at a big mall and had kind of an explosion of the equipment that he was using and burned both of his eyes.
Wow.
And a young guy with a 6-month-old daughter, and he went to a couple places. And they said there's nothing to do. Your eyes are too severely burned, and we don't think you're going to get your vision back. And so he did find a corneal surgeon in Kansas City. Now this guy's only about a month out from his injury, and he went to the doctor and said, "Listen, we're going to do a stem cell transplant and a corneal transplant. You're going to get your vision back in a couple weeks." And the day before the surgery, I got a phone call from his local optometrist saying, "Could you see my?" And it turned out to be that's his brother-in-law, by the way. "Can you
Oh,
see my brother-in-law for a second opinion because he's scheduled for surgery?" And I said, "I'm happy to see me." He came out. So, Robert, one of the rules we have in chemical injuries and thermal injuries is that we never operate early on these patients.
right.
A chemical injury takes a year, maybe 18 months for the eye to quiet down. So there's no way we would operate. We want to quiet the eye. We want to get the eye healthy and get the acute. And the same thing with other, the autoimmune diseases. We want to treat the autoimmune disease first, and then thinking about doing the ocular surface transplantation second. So I said to him, we have a chance of getting your vision back. And he said, "Okay, I know you do a lot of these. We read up on you. When can we start?" I said, "I'll see you in a year. I, you
Right.
know, I mean, I'll see you in 4 months to do a checkup to make sure you don't have glaucoma thing, but we're not
Right.
doing surgery for a year." So he hung in there. He canceled the surgery with the other surgeon, and it was interesting. His first surgery was a an ocular surface stem cell transplant. Now, when we took living cells off his sister, but his injury was so severe, we had to combine it with the deceased donor. So when we combined, because we didn't want to use both of her eyes for one eye because he had two eyes injured. We could only use 40% for one eye. And then we combined the deceased donor to give us 360 degrees of tissue. That's actually what's called the Cincinnati procedure, that operation where we combine donors. So obviously he still didn't see because he had opaque cornea. And then he came back, we took care of him. And 3 months later, he got his corneal transplant. But when we couldn't see through that cornea, we put the new cornea on, he had a white cataract. So he still
Mm.
didn't have vision.
Wow.
So now I told him, we need another few months before I can get your cataract out. And
Right.
so one of the nurses was saying to him, your daughter now, she's almost 2 years old. He said, "Yeah, I have not seen my daughter in almost 2 years." But I said to him, "When we take this cataract, you're going to see your daughter that day." That's one of the more rewarding things about seeing when you can get vision right back, and you've done it with corneal transplants. But
Right.
so he took his cataract out, and then he saw his daughter that night for the first time, and it was really moving. And the nurse had asked him, "Are you going to have any more children?" And he said, "This blindness has been so traumatic. I have this beautiful young daughter. We're not having any more kids. We're happy with our child." So then 6 months later, we start operating on his fellow eye, and he comes in, and the nurses were saying, um, "I've been talking to your wife, and she told me she's pregnant." So, after he got vision back and he got the confidence that he could be, you know, uh, someone with vision to take care of his children and to work again, they decided. So the next child they named Holland.
Wow.
That's the child's name, which was there's probably nothing more rewarding than a patient can do.
That's it.
'Cause I remember that his wife said to me, we really would like to, honor you by naming our son after you. And I said, well, Edward's kind of an old-fashioned name. Nobody gets named Edward anymore. She goes,
Right.
no, no, we don't like Edward. We like the name Holland for his first name. So, and
Wow.
they've gone on to have more children since then. And our
That-
vision in both eyes, wonderful family, back working, and it's a pleasure to see them every time they come in.
Yeah, that's such a heartwarming story. I'm
Yeah.
glad you shared that with us. Let me ask you about these transplant coordinators. You mentioned there's no funding for that, and you have a foundation that helps you with that. But what do other corneal surgeons and other academic institutions do? Does your foundation help to support transplant coordinators all over the country, all over the
Yes.
world?
So one of the things we realize is, to get a program off the ground, we talked about the quarterback and we can identify young, talented corneal surgeons, but, to tell them they have to go out and depending on where they are in the country, a nurse's salary can be 100 to $200,000 a year. I mean,
Right,
so to tell them they're going to have to go find a transplant coordinator and we'll help you get started. So really it was Bob Dempsey's idea that, listen, the first financial support we're going to give you is to hire you. And we did most of these programs, we start with a part-time transplant coordinator because they're not that busy yet.
right,
We are going to fund, a 2/5, typically 1 to 2 days a week, FTE transplant coordinator, and our foundation is going to help you find that person and pay their salary. So typically, it's been different from different programs, but usually they'll find a renal transplant coordinator, and they'll take 1 to 2 days of her or his or her time, put them on their team, and it's part of this collaboration with renal. So first of all, those transplant coordinators are already trained. They know how to manage these patients, and think about what they do. Well, even healthy patients are doing well have to have all their labs checked, right? The side effects of medications can be toxicity to the kidney, the liver, the bone marrow.
right.
And so we have labs at minimum 4 times a year, but more often than that. And then they have nuisance side effects like, headaches or upset stomach. So we have to adjust the meds and sometimes we have to switch them. So, if a corneal surgeon gets busy, he can't take every phone call or email about diarrhea, that
Right.
has to. So having this person to be really the first person to interact and handle, my transplant coordinator has been with me now for 12 years, I think.
Wow.
I mean, she handles 90% of the issues that come up. Now, and a lot of things I can do myself because we've been doing it so long, but we still email, our partner at University of Cincinnati, Amit Govill, who's head of renal there, and we'll have an issue where, a patient can't take one of the medications. We want to switch the medications. When do we do it? How do we do it? What's the
Right.
dosing? So, or the pre-op diagnosis of the patient, they may have some medical issues that we're unsure of when we email that person. So, the renal doc doesn't really need to see the patients. He needs to understand their management issues. And so we still collaborate many times a week with our partner in renal.
It's amazing that you have the time and energy and patience to do all this because you're a well-known, world-famous cornea specialist to begin with, even before undertaking this. How have you managed to do this, and what personally drives you to tackle this challenging and underfunded area of ophthalmology?
Well, I always give credit to one of my great mentor in ophthalmology was Richard Lindstrom at the University of Minnesota.
Yeah,
And Dick had this idea when I was a resident, he asked me, to come back and join him, and I would have been the fourth cornea person. But in the middle of my cornea fellowship at the University of Iowa, he called me and said, we got three guys that all kind of do the same. We're all general cornea, and really high risk corneal transplant. Immunology, I think, is the future. And so I want you to do another fellowship to learn. And I always joke with Dick, I'm young and poor and out of money, but he always points out not only did he help me get a fellowship at National Eye Institute, but he also put me on the tenure track at Minnesota with a salary while I was a fellow. So Dick
Well,
really he was a very clever guy. So, but we didn't, so back then, that was 1987 when I joined, we didn't know about stem cells. So
right.
we promoted a high risk corneal transplant program. We wanted to take rejected corneas. And all we did was put them on medication that prevent rejection. And so if patients had just pure rejection problems, so let's say you had a keratoconus patient, you did a corneal transplant and they rejected a couple of times, we could get that patient with systemic anti-rejection meds and they do great. But we had a bigger population that didn't do well, and those were the chemical injuries, the thermal injuries,
Yeah.
Stevens-Johnson patient, because we didn't know what we didn't know, and so we were treating them all the same. And really, because I had done lots of corneal transplants in these patients with limbal deficiency, and they all failed, I had a big population of patients that I was obliged to try to fix. So I kind of transitioned to saying, okay, let me figure out how to do ocular surface stem cell transplants and make them work. And that was a long, I'd say we learned a lot at Minnesota. We learned a lot more with the collaboration I have here in Cincinnati. And, it took us a while to figure it out, but our Cincinnati protocol is the way to manage these patients. And, by default, I just had them. And then once you start publishing, as you know, Robert, on a topic, the patients find you. And
Right. They can look
and,
it
and
up.
cornea people are happy to get rid of them. You, you know,
Very
you know,
difficult to manage.
yeah. So and we're happy to have them. And it's really been my passion for the majority of my career.
That's great. So I want to thank you and congratulate you for doing this incredible work that nobody else has done. I assume you want people to donate to the Holland Foundation for sight restoration. So I'll
We
post
we
that.
we we would love that. We need to raise money to, what we found out in all these programs when we give the starting salary for a transplant coordinator, when the program gets busy, that person becomes self-funded. We don't need to fund their salary forever. It's 3 to 5 years that person is covered. But we have, patients in need for travel and another kind of story that we have a disconnect with. If you're going to donate your kidney to your brother, his insurance will pay for your tissue typing to see if you're a match, right? So
Mhm.
they're going to do tissue typing on you and your brother, and there's a code for that. We don't have that in ophthalmology. We can do tissue typing on the recipient patient, but their siblings, that's out of their pocket, and that's somewhere $1,500, $1,800 per donor, and
Wow.
so that's another obstacle on the financial side. So yeah, donations are greatly appreciated. Our goal is to create multiple centers regionally in the United States to get these patients referred in. And, we've really, this last year has really taken off. Our goal, we have an annual meeting. We had about the first 2 years of our annual meeting for ocular surface stem cell transplant here in Cincinnati. We had about 20 surgeons. This year, we're going to have, it looks like 25 new surgeons
Wow.
that were not involved in our educational program last year are going to be coming this year. In addition to having formalized courses at the American Academy of Ophthalmology and American Society of Cataract Refractive Surgery on this exact treatment management.
Great. Well, I'll make sure to post the website for your foundation, and hopefully that'll get you millions or tens of millions of dollars. And then we can open a center in every state so that patients don't have to travel all over the country to get
We
their
we need
treatment.
one in New York City.
Yeah,
Now think about that. Greatest city in America, and we take care of a lot of New York patients. They now can go to Boston, but
right.
we need a passionate corneal surgeon to start a program in New York City. Help me do that, Robert.
Well, I'm on the medical board of the New York Eye Bank for sight restoration, so I'm going to make sure that everybody gets the word there. And after this is posted, I'll make sure I'll send an email so everybody can watch it. And hopefully, you'll get a few corneal transplant physicians interested and get the New York City area started.
That'd be great.
All right. Well, thanks again very much for taking the time to educate us about this extremely important topic that's been neglected for a long time. We really appreciate it.
Thank you.